I'm told that a year from any talk, you will only remember at most one fact that you got out of that talk. The fact I'd like you to remember a year from now was that introduction. It was generous, and I'm gracious. Now, how do we turn this on, phone?
Turn the slides.
Slides.
You need to share screen.
Oh, okay. 1 second.
It has to be.
The host will allow me to share the screen.
Oh, let me do that. I apologize. I think the default setting is that only we can do that. Give me a moment. All right, you should be all set.
Click it again. PowerPoint. Go all the way up.
And it's David, right? The last one.
Click that one. First slide. There you go. Is that right?
Yes.
Okay.
All right. I'm flattered to be asked to do this. Our respect for Dr. Litvak and for the team that he put together, and the recognition that every single member of the team had a very important role when they spent 8 months with us. So I'm flattered and pleased to be able to be here. Let me move this up so I can see. St. Thomas Community Health Center is now a federally qualified health center. However, it was started in 1987 by the Residents Council of the St. Thomas Housing Development, which was, I think at the time, the third largest housing development in the country, rife with all the problems that housing developments were said to have. But the resident council elected leadership went to the city and said, you know, in 87, your primary care, if you were Black and uninsured, that was redundant to say that, but your primary care was the emergency room or the charity hospital or the charity hospital clinics. At the time we opened, it would take a year to get an appointment in the clinic. And at the time we opened, the wait in the emergency room was often 12 to 18 hours to be seen. So the elected leadership of the resident council went to the city council members and said, look, we would like to have something that's an alternative to that. So to their credit, they took one of the units of the housing development. They said, we're going to make a clinic here. There were 2 nuns from Pittsburgh that we worked with in setting up the clinic. And so we began the clinic. Now, at the time, I was the chief of medicine and director and vice president of the foundation at Oxner Foundation, and I ran the residency program. So I could bring some of the residents down. And when I brought the first group of residents down to the clinic, feeling, to be honest with you, pretty noble. I mean, you know, we're coming down to really help here. And the people at the clinic, part of a consortium, said, can we talk to you a minute? Said, you know, you look like a pretty nice guy, but you don't understand. We're not dying of diabetes and hypertension. We're dying of violence and the effects of poverty. And that we feel that those 2 things, violence and the effects of poverty, have their root cause in 400 years of institutionalized racism. So we view institutionalized racism as the core health problem in the community. If you want to come help us fight that, you're welcome. But if you're just coming down to see some more patients for you to go back and talk about what a good job you did, please take your do-gooderism somewhere else. This was a real, the budget was really we had modest needs. We had modest money. It grew a little bit because we, in 91, moved over to a building that had been a burnt-out school, and we remodeled it. Dr. Mary Abel became the medical director. She's now the associate CEO. And Dr. Abel was the provider working there and member of and related with the community. We started in 87, very low expectations. We had really done okay until around 2013. Part of doing okay was in 2005, we had Katrina. You either sank or swim, literally, in that situation. We grew where there were Katrina-related revenues. We grew. And then in about 2012, the state of Louisiana decided not to expand Medicaid. So when the patients still had a lack of insurance, and by this time, we really were having financial problems. But, you know, it was nothing new to us to have financial problems. Mary could tell you that for the first number of years, her 401k was in name only because they rarely had cash to put in it. So, but by 2013, early 2014, Robert is our CFO, and he was reminding me of those days. By 2013, we really had basically no cash. We had been, we had.
That's shrinking, Dr.
It is shrinking. I was hoping it'd go the other way. Okay, hit the button. As you see, this is March, but it's year to date for 2014. Steady losses. We were presiding over a really sinking ship. We had the best of intentions, but it was going down. HRSA, which creates FQHCs, did and just before this, did our triannual inspection. And they noticed that we only had 0.5 operating days of cash on hand. We said, oh yeah, we know. Our goal is we're going to have 30, and then ultimately we're going to have 60. We could have picked any figure out of the air because there was just no chance that we were going to do anything that made anything much better. So it's in this backdrop where we know that things are really in trouble. We're meeting every day trying to decide what we're going to do about the clinic. Do we cut costs? How do we cut costs? What do we do? Well, on your right is a picture of Holy Name of Jesus Catholic Church. And in early 2014, a very prominent New Orleanian died, and I went to his funeral. Joe Jurisco, I was at Oxnard, chief of medicine at that time. Joe Jurisco was head of the emergency rooms at Oxnard, and he was going to the funeral. So he joined me in line, and we started chatting. Now, Joe, I knew, had a history of being very effective in organizing and setting up and having emergency rooms throughout the Oxnard system, that he had developed quite a reputation for this. And I was telling him about the problems that we were facing at the clinic. And, you know, Joe said, well, I understand what you're doing. He said, I don't think there's anybody locally that's going to really be able to help you out. The only person that I can think of that might be able to help you out is Eugene Litvak in Boston. He said, I really urge that you get in touch with him. So I did know Peggy O'Kane, who was head of NCQA, and I knew that she knew Dr. Litvak. And I called her and I said, Peggy, You're pretty familiar with us, and here's our situation. Is Dr. Litvak the real deal? She said, absolutely, he's the real deal. The bad news for you is you can't afford him because he does big things and he does them well. I'm not familiar with him doing anything as in your ballpark. But nonetheless, we were in vacation and I had time to kill, and I Googled and called Ming. Ming Khan could not have been nicer to us. He listened to our story. He said, he didn't have to tell me, but I knew IHO charged a lot of money. But he also knew, because I was honest with him, I could put my finger on $88,000 in cash that we could come up with towards this consultation. And so he said, let me go talk to Dr. Litvak. So soon after that, we got a proposal from Ming that would be $150,000 for 6 months. And Ming pointed out, okay, we're saying to ourselves, what could IHO do for this struggling clinic and this under-resourced clinic in this under-resourced community? And then in talking with Ming said, here's what we anticipate the benefits to you would be if you had us come down and take on your situation. I looked at that list and I thought, man, if we could get 3 of these, it would really help. If we could get 5, we might be able to turn this thing around somewhere down the line. You sign us up. So I came back to my decision team, my management team. There were 5 of us that met every day talking about what do we do? Where do we cut? What do we cut? Is there any source of money out there? We had pretty much exhausted that. So I said, I've got great news. For $150,000, we can get this wonderful consultation that may save us. Now, I want you to understand the mood at that time. Now, these are 5 people that get up every day, dead set on doing the absolute best they can. And they brought 5 different perspectives to this. And they said, well, first of all, we've had plenty of consultants in the institutions that we've been in, and we know the deal, stickies on the wall and all that stuff. And they leave, and the only people we can be sure got any benefit from it is them. But so, and at the same time, we're in this really tight team of resources. We don't have enough people. We don't have enough money. We don't have, if we took the money and put it into this consultation, we might have to close sooner. So we had majority vote against it, but there were a couple things. One is I trusted Joe, I trusted Peggy. I felt that you could call this karma or networking or Holy Spirit. I call it the Holy Spirit, whatever your higher power is. He was there with us. And so I also had the general knowledge that the people that create a problem aren't usually the ones who can create the solutions for that problem. So we had a supermajority vote. We understood that the clinic couldn't afford it. So Mary and I felt so strongly that we wanted to do this that we borrowed the money from her retirement plan and paid for it. Now, for those of you who are looking for side notes from this, this is an observation, a real world founder mentality. We are not going to let it go. Founders are not going to let something go. They have too much of their heart and soul and their identity tied up into it. And we really felt like that this was a good opportunity for us. So we decided we had some real thoughts about what will we get from it? But we all knew that we had been doing this a long time. We had a lot of assumptions about how to run a health clinic. I'm going to go through a few of those assumptions and tell you what we learned when we applied operations research principles to them. The first assumption that we all had was that if we had more rooms per provider, we'd have more throughput. That's pretty simple, pretty straightforward. They all had time constraints. They just had more rooms. So the first thing we did was the time utilization study, and I put this slide up to show that we thought that standing there with a stopwatch would be pretty easy, but when you really want to do a time utilization like IHO does, they compared everything that we were doing. We compared the MA working with a provider. Did they have the same job of when they went in the room and left the room and that sort of thing? So overall, what we recognized was that the time analysis showed that a lot of people were doing a lot of things. It also meant that it was hard to collect the time accurately. But we finally realized that if we had 3 rooms, only thing that we would accomplish would be that the patient would be waiting in that 3rd room rather than the waiting room. The next assumption that we looked at was that new patients caused us, they were harder, more complicated, took more time, and they caused us to be behind schedule. Again, looking at the time utilization, let me just show one. Here's one of the providers. Here's her MA, nurse. Here's what the activities that they did. Here's when they started something. Here's when they completed it. Here's when the provider went in, that sort of thing. So that we began to recognize that there were any number of delays that we didn't really anticipate, but that it made certain that the type of patient, whether it was a new patient or an old patient, had nothing to do with it. So in that same vein, we were pretty sure that we were using our time as efficiently as we could. But once we started looking in detail, scheduling was done on every provider every day, so that we knew what their capacity, how many appointments they had available, how many of them were scheduled, how many of them actually showed up, so that we recognize we're not getting into reasons, but none of us are nearly as efficient as we anticipated being and as we thought we were. Now, one of the first things, one of the strongest health principles in medicine as a physician is that continuity of care is absolutely essential for patient care and quality. It also is at the core of who we are. This strikes at my identity. All of my patients would only want to see me. None of my patients would want to see anybody else. And so when we then had our first meeting with Dr. Mike Long, Dr. Long had the advantage of being a physician and therefore being able to be direct with other physicians. So Dr. Long started this and said, well, I understand. What do you think about continuity of care? And we said, oh, it's the sine qua non. You can't do anything without continuity of care. He said, would you be interested in knowing that pardon me just a second. Would you be interested in knowing that 70% of research shows that 70% of the patients prefer to see someone who can solve their problem today rather than wait 2 or 3 days to see, quote, their provider? That was hard for us to accept, but it had a certain logic to it, and it had some data with it that we filed that away. We didn't quite know what to do with it, but we filed it away. Next assumption that we had was that no-shows are just essential, are inevitable. And I have to tell you, I'm not certain that was not right, because we have tackled the no-show problem. I only had 45 minutes, so I can't tell you what I've tried to do dealing with the no-show problem since 2005. Nothing's worked. And we continue to have no-shows today. So we're building that into our model. The next assumption that we dealt with, is that our operators must not be efficient, because we had lots and lots of dropped calls. And again, that must be some human's fault, right? So somebody wasn't doing something they should be doing or working hard enough. So then when we looked at the operators' load and the templates that we were given, it became very clear that there were a number of times during the day, a number of days during the week, when there is no way the operators would have been able to answer all the calls coming in. Now, we did feel that we could do better than having 100 to 120 dropped calls per day, so that we knew that we were going to have to address that. And our core health belief is that the problem must be with individuals not doing their jobs. Somehow we were able to avoid the truth that systems work exactly as they are designed to work. So having to accept that meant a lot of things. It meant that we had to have some role in it. So what we didn't understand was exactly how much of this was system and how much of this was effort or planning or management or good CEO stuff. But what we came to recognize was that we were trying to deal with random demand. And we were having fixed capacity, and that fixed capacity was being altered now from time to time. Now, looking at the equation that you had on the board when I looked into your class, I'm pretty sure that I don't have to go into this, but while we didn't understand what to do about random demand, we had about a week and a half with most of the people associated with IHO making sure that each of us understood the queuing analysis, the queuing principles, the queuing methodology. So we actually did.
Oh, what happened?
I didn't do anything.
Sorry.
Sorry about that. I assured Dr. Litvak that I had Fong Tran, our IT person, in the room to make sure there were no signal difficulties. But Dr. Litvak's team helped us understand that there are ways to address trying to match random demand and understand when it's random and when it's not. But when we finished with this, we were pretty sure we're the only clinic in town that was up to speed on the queuing theory. We also understand that there are different levels of operational research. Most of my life as a physician, I've heard people speak of big R research and little r research. Big R research is generally speaking the research they were doing. Little r research is generally speaking what other people are doing. But this was a clear example to us why this team and this group of people helping us with operations research was a perfect fit for our clinic. So I'll give you an example, because this is an example of the queuing model addressing the call center. Now, Dr. Litvak, I want you to understand that I personally, speaking for myself, thought this was rather arcane when I opened it before we started working with it. But I want you to know that you got through to us enough to know this queuing assessment was done this year, because we had a new phone system put in. We couldn't tell how many blocked calls we had. Once we did get a way of telling how many blocked calls we had, we were able to apply the queuing analysis and come up with estimates of how many operators we're going to need at different times on different days, and we can flex schedule. So for those of you who think that before I leave that, Mary and I were talking about this talk over the weekend, and we said, I hope that the people that you're talking to will be able to understand that the things they're learning at Harvard are applicable in clinics like ours. And so that I do hope you're doing that. So, well, once we went through all of our assumptions and blew them out of the water, we decided that it was recommended that we go to an open access model. Now, I do want you to understand that if you have physicians that you talk to and say, let's take your practice and make it open access, you will make them all pale, because there's a real concern. This is better. There's a real concern of loss of autonomy. But after several months of visiting with the team from IHO, when they made the recommendation to go to an open access model, it made sense to us. And we were ready to give it a try. So, and when we gave it a try, what we decided was we wouldn't schedule any appointments for 3 months. We put in our literature, we communicate with our patients, we'll see you any day you want to be seen. But but we're not going to give appointments for 3 months. And then we thought, well, the rest is going to be easy, because during this time, when we open back up, the operators can just be making the appointments. This turned out to be, for us, the hardest part to implement, because what you need when you're going to do open access is we needed them to start at 8 o'clock in the morning, fill that appointment first, and go up through the rest of the day. If you gave somebody a 2 o'clock appointment when you had 11 o'clock opening, that was not what we wanted you to do. So, but the operators were really placed in a role where they were trying to urge appointments and encourage appointments that was much more proactive than they usually are. So what was settled on was that there would be a mandatory script. Each operator, this is about 12 pages long, and each operator really got coached and skilled at selling and encouraging an earlier appointment. This was, in many instances, motivational interviewing at its best, because people would say, I want Dr. Abel in the afternoon. I'm not sure I can offer you that, but I can offer you Dr. Emsice at 11. Then, depending on how enthusiastic you were and how you made it sound, the operators got very good. This has been probably the single hardest thing to maintain over the years, because over time, those scripts just tend to fall by the wayside. Yeah, we have them. Oh yeah, it's in here. It's here someplace. And each new director of operations, I ask them to write the script again. And it's it's always tailored, but that has been hard to implement, to keep going over time. Here's kind of where we are now. This is some of the information that we follow at the moment. We do this for all of our providers daily. We have this again is the offshoot of the information that we collected with IHO. We follow this on each provider each day, the available appointments, how many of them were scheduled, what percentage, i.e. were booked, how many of the appointments showed up, and how many were listed as no-shows. And we're continuing to try to, I will say one thing briefly, we don't use incentives. We felt like, we believe the literature about that if you use incentives, you have the risk of changing a social contract into a financial one, and we're going to lose in that circumstances. We've come a ways. We really recognize that everybody in that room, when we decided whether to do that or not, was doing the best they can. And everybody really felt the weight of having the only economic engine that the community had, and it had been through a lot, and it was going to close on our watch. And that was hard on all of us. But once we began, the decision was made to contract with IHO. Everybody was 110% behind it. Everybody worked hard to try to make it work. We still are trying to use as many of the principles as we can. We did run into the same as everybody else did. March 13th of 2020, the clinic was closed for in-person visits. We had 5 employees come down within 3 days with COVID, 2 of them quite sick. The city went on lockdown, and Dr. Tran, who's sitting in the room with me, is head of our IT. And on Friday afternoon, Dr. Tran went home. We had never done a telemedicine visit. On March 17th, 4 days later, we didn't begin in a piddly fashion. By March 17th, we saw about 80 to 90% of our usual visits per day by way of telehealth. He did a magnificent job of finding platforms out there, getting us connected to getting us put on them. The one that we liked the most, but access to a couple of others. We learned a lot about it. We have now information on probably close to 60,000 telemedicine visits. And we know that number stays fixed. Only about 70% of them can have an audiovisual encounter. 30% have audio only. We, as a part of that effort, we successfully applied and got an FCC grant last summer of $1 million to purchase specialized smartphones. They have been modified. Originally, they were modified to do only one thing, and that's to give a telemedicine visit. That was so hard to use that we've now gotten the vendor to let us give phones out that they can have visits. They can also text, and they can also make phone calls, and it helps them with their social isolation. We're in the process now of trying to work through who should be eligible, most eligible for these phones, how should we get them trained, and how do we make sure that we get the audiovisual visits that we can. This is where we are today. We have a bigger everything, and we have had COVID losses and we've had COVID gains. We had COVID financial hits and we had COVID revenues that came in. So it's sorting itself out. But the main thing I wanted to do is to come back. We want to let's look. When Ming told me of these 10 things that we will get, and I was willing to say, I was euphoric if we got 4, and look at them. As we look at them again, this is each one of those things came with a dedicated area of study about it and dedicated ability to measure and improve. And we're trying to do that. I actually have my son-in-law, who's a psychology researcher at Hopkins, helped me write an ad for a director of data science because we're a senior data science analyst. So each of these things, I think, will help us continue with the lessons that you helped us learn. We don't pretend to be as good at data as we'd like to be, but you've taught us the value of it. You taught us the value of really good data. And I really want to make sure that you understand, that we understand that we don't have any question about this. We feel that IHO saved the St. Thomas Community Health Center from closing in 2014. I had already talked with our board chair about should I go to Daughters of Charity or should I go to Access Health to talk about giving our revenues to them. So that was in February. That's when I knew I couldn't make July's payroll. So we weren't kidding. We really needed help and we got it. So, I'm so happy, Dr. Litvak, to be able to reinforce once more that these were lessons we got that turned us around and that we still, maybe imperfectly, maybe not so well, but maybe sometimes pretty well, we still try to follow those principles. Your team did a good job of educating us, not just showing us what you were doing. So I'm grateful to have the opportunity to encourage you that there's a world out there that needs your service. You're not going to have to stay in academic research, that you can go out and make a living. That's pretty much all I wanted to say. I did want to just show you, this is our website. If you want to know any more about us, it's stthomaschc.org. This is our group of leadership. The first 5 all went through the IHO training era. And again, I just want to thank you for the opportunity to refresh our memories and to show you a little bit about the real world application of a lot of what you're learning.
Dr. Erwin,